If you've been told that your uterine lining is too thin, you've had IUI or IVF cycles that have been postponed or failed because of this thin lining, and now you're wondering, is there anything I can do naturally to help my uterine lining? This episode is for you. I'm Dr. Jane Levesque, and this is the Natural Fertility with Dr. Jane podcast, where we help couples uncover the real reasons behind their fertility struggles. And today, I want to break down why some women will struggle to build healthy lining, what a thin lining is really telling us about your body, and the levers that I work on with my patients to help them improve it. These are not quick hacks or quick fixes, but real root cause work. So the first idea that I want to share with you is that a thin uterine lining is not random, and it's not just bad luck. Your menstrual cycle is your monthly report card. So it's telling us about the level of hormones that you have, the levels of nutrients that you have circulating through your body, your blood flow, your blood pressure, your overall resiliency, the amount of stress that you have been under. So before we jump into treating the uterine lining, we really need to understand why it's so thin in the first place. So let's start with what might be going on. And do you actually know if you have thin lining, and how thin is it? This is where proper testing is really important in understanding the time of cycle that you are getting these tests done. For women, you never want to run tests randomly. We need to time it with your cycle. So when we're looking at assessing uterine lining, we either want to do it right around ovulation, or we want to do it in the second half of the cycle. And sometimes we need to do it both times to make sure that things are lining up. Now, if you're getting an IUI, or you just want to get an antral follicle count to see how many follicles are being recruited, I recommend to get that test done anywhere between day 8 to 12 of your cycle, depending on when you're ovulating. We want to see how many follicles your system is recruiting, and then we want to see the health of the uterus during that time. So you're not just assessing uterine lining, you're also looking for fibroids and polyps or any structural issues, and then of course assessing and looking at the ovaries and the amount of follicles that are coming on and being recruited. But between day 8 to 12, you're looking for that lining to be 5 to 6 millimeters, sometimes 5 to 8 millimeters, but really not below 5, because the estrogen is rising, and estrogen helps to lay the foundation for the uterine lining. If you were testing in the second half of the cycle, so day 19 to 23, we want that lining to be anywhere between 8 to 12 millimeters. So below 8 is going to be much too low and is associated with poor implantation rates and poor pregnancy outcomes. Anything above 12 and even 13, 14, now we're thinking about things like hyperplasia. And again, it is associated with lower implantation rates and lower pregnancy outcomes. So if you're going through an IVF cycle, it's really important right before transfer that your uterine lining is optimized. And if you haven't even considered or done IVF, but maybe you've done an antral follicle count right before you signed up for an IUI, you still want to get an idea of what's happening with that uterine lining, whether it's in the first half of the cycle or in the second. And the common approach, once you figure out that my uterine lining is thin, is let's just crank up the drugs. Let's add more estrogen, let's add the progesterone, let's add this tea and this food and the pomegranate seeds and this juice and this herbs. You're just essentially trying to throw everything at it to see, because the research has showed that having more pomegranate juice and the polyphenols and the vitamin E or the whatever else the research is showing that this is good for uterine lining, so I'm going to try it. Now, I love research and I think it's fantastic, but here's where most people are missing the point. The problem is you don't know why the lining is thin in the first place. And if you don't know why it's thin, you're essentially just guessing in terms of the treatment that's going to work. And so I'm going to break down kind of the 3 biggest reasons why your lining might be thin. Like I said at the beginning of the podcast, if your lining is thin, that's telling me something about your cycle, about your hormones, your nutrient levels, your stress, your microbiome. So I'm going to break it down into like these 3 big components. The first one is, do I actually have enough bricks to build the lining? So the nutrients and the blood, what is within the bloodstream. Then do I have enough builders? And think about builders as like signals. So what about the hormones and the follicle development that could be happening? And then is the construction site actually safe for me to build? Meaning the inflammation, the blood flow, the scars, the microbiome, and the stress. So that's, if I look at it as the analogy of we are building lining, and we literally use the construction metaphor, is do we have enough bricks? Do we have enough builders? Is the construction site safe for us to build? So if we skip all of that and just go straight to, let me just try this because I saw that this worked, we're essentially missing out on a big component of treating the root cause. A really good analogy for this, I'm sure you've heard of the saying, fear doesn't like to be named, and then as soon as you name the fear, you tend to feel much better and things, quote unquote, resolve. This is the same when we're treating any issue. You need to name what you're actually treating. And saying I have thin uterine lining is just not going deep enough. And so when we're not asking the deeper question and staying curious of why is that lining thin, what happens is you start throwing everything at it, and then some things stick, some things don't, but eventually it stops working because you never really addressed the real issue. And for some of you, you just might be overwhelming your system entirely, which actually then blocks the system from being able to receive the nutrients that you're trying to give it. So let's go through these 3 points. Do you actually have enough bricks to build the blood flow? Now, I'm talking about the nutrients in the actual blood volume, and these are the things that I will look at for my patients. We want to make sure that your iron and your ferritin levels are in good range. So low stores usually mean that your body literally cannot build more blood and it cannot move that blood. Now, I've seen women with high ferritin have thin lining and low ferritin have thick lining. So this is where we need to just assess each individual woman and see what could be the issue for her. We also want to look at things like B12 and folate because those are needed for healthy cell growth and repair. They're needed for red blood cell production. I'm also usually going to look at the full methylation cycle because B12 and folate, the folate cycle and the methylation cycle cannot be separated. And so if I just look at the folate cycle, but I don't include the rest of the methylation cycle that, I have been talking about extensively now, we tend to miss the bigger issues because it will also depend on your genetics. Some women will need more B2 and B3 and B6, cysteine, glycine, electrolytes, you name it. So we want to assess the full methylation cycle. Protein intake. This is actually really underestimated for some reason, but your body uses amino acids to build tissue. And that methylation cycle that I was just talking about, there's a lot of amino acids that are required in order to make that methylation work properly to help you rebuild those red blood cells and to help you therefore increase blood volume and nutrients. Because your body is very smart. It's not going to want to lose blood when it already has very little of it. So, and obviously it's not going to build that thick uterine lining. The other thing that's really underestimated is hydration and electrolytes. So to have blood volume, you need hydration, you need water, but you don't just need water, you also need to have good blood pressure to actually push the blood out. And a lot of women who have thin lining have low blood pressure, and usually it is connected to adrenals, their adrenal glands being exhausted. So things like sodium and magnesium and potassium, for some molybdenum, manganese, zinc, all are going to be really, really important. So again, this is where I just test because every woman is so different. But understanding if you actually have enough nutrients and blood volume is a big reason why you might have really thin uterine lining and very light periods. So then we go into the next component. Do you actually have enough builders? And I think about those is the signal. Do you have the actual signal that tells the body you need to build more lining? And this is where the hormones are going to come into play. So estrogen helps thicken the lining in the first half of the cycle, while progesterone will stabilize and then mature it in the second half of the cycle. So if the ovaries aren't making enough of either estrogen or progesterone, or if follicles aren't developing properly, then the uterus never gets a strong build signal. You need to build up this lining. So this is where we get into bigger diagnoses that we want to understand. Is this PCOS, or also known as PMOS now? Is there a lot of really small follicles but not very big ovulation? Is this premature ovarian insufficiency or diminished ovarian reserve, where the ovaries are just not responding to the brain in the same way, and not only one follicle is barely being recruited, instead of 4 or 5, and we're getting really good growth of those follicles? Or are you in perimenopause and your hormones are simply starting to drop? Most women are terrified of that word when you're trying to conceive, but the truth is our hormones start to decline usually at the age of 35. We start to see that progesterone drop. And then by the time you get into your 40s, you're definitely going to see progesterone and estrogen drop. And it very much depends on your level of inflammation, your level of stress, your mitochondrial function, your level of nutrients, if the body initiates that shutdown a little bit sooner versus a little bit later, and how severe that shutdown happens. But when we don't have enough hormones, and we can definitely test those things, then absolutely it can still be connected to the fact that you don't have enough nutrients, things circulating in the body to build those hormones, like protein, like hydration, like healthy fats, like good digestion and B vitamins. But it could also be that there's something going on with the signaling between the brain and the ovaries. So thin uterine lining is never a complete diagnosis for me. I really want to go a little bit deeper. Now, the last thing that we want to look at is this construction site safe. Is it safe for the body to line uterus, to line, the endometrium within the uterus? And this is where we're now looking into things like inflammation, blood flow, structure, microbiome, and nervous system. So it's really just about the environment of the uterus. If there's chronic inflammation in the pelvis or in the uterus, if there's scar tissue or adhesions, whether that's from multiple surgeries, and endometriosis could be part of that surgery, but also if you've had a DNC before, maybe if you've had a C-section before and now you've started to experience low uterine lining. Chronic infections in some women can also progress into further issues like the Usherman syndrome, where essentially the uterus just gets filled with scar tissue. That's not a common thing that happens for a lot of women, but I do see a congested uterus in a lot of women. And whether that's polyps or fibroids, or they did have a C-section, or they had a low-grade chronic infections, they had other surgeries. Essentially, there's just really poor blood flow. And then we add the stress, the inflammation, the oxidative, damage that's coming in, the nervous system that's stuck in fight or flight. Essentially, there isn't enough room for the uterus to then form proper endometrium and thicken it. And then I typically don't just see this. I see the hormones that are not producing, and the blood flow, and the nutrient levels that are also low. But this is something that we need to talk about. The other component that doesn't get talked enough about is the uterine microbiome and kind of the chronic low-grade infections like endometritis. Most women will walk around with chronic inflammation in the uterus that's really low grade, and they will not know about it because they're not really going to have super painful periods. They have a little bit of discomfort, but it's just this general inflammation and this puffiness that they feel, or it's the lack of being able to get pregnant, or they're just keep having recurrent pregnancy losses. We have to look at the uterine microbiome. I typically look at the vaginal microbiome as the first line, but it doesn't necessarily reflect what's going on. So when we take really good history and we look at the symptoms, then we can tell if uterine microbiome is something that needs to be addressed. And if it does need to be addressed, depending on what the infection is, we then need to curate a proper protocol. I will record a whole other podcast on endometritis because I think it's wildly misunderstood by the conventional system and by kind of the holistic natural world, because we assume that if we just take antibiotics for 7 to 14 days, then that infection is cleared, and just follow up with some probiotics and things are good. But in reality, that's not really how it works. It's not I rarely see women take antibiotics for 2 weeks and go, I feel amazing, and then they conceive within, a couple of months. Typically, the microbiome is really unhealthy in general in the gut and in the uterus and in the vaginal microbiome and potentially in the seminal microbiome, and that's why the infection in the uterus is there. And none of those things are addressed when the woman is just put on antibiotics for 2 weeks. We're not addressing the terrain. We're just basically trying to kill everything off and then hope that introducing the probiotic species, they will now stick. And like I said, I rarely see that that's actually the case. So if you have endometritis and then you have low estrogen and I give you estrogen tends to feed infections. So if you already have a predisposition to, let's say, higher estrogen, if you already also maybe have endometriosis or fibroids, then we're going to cause, some issues in the system without properly understanding everything that's going on. So what I want you to remember is that your uterus doesn't live in isolation. And if there is inflammation, if there is an infection within the uterus, if the immune system within the uterus is just not quite right, there are usually other issues that are going on that we need to address and to look at. So an example that I use, one of my clients who, she had 8 rounds of IUI before they came to me, and they had uterine lining that was 2.6 millimeters going into IUIs, and they just allowed them to keep doing the IUIs thinking that there was something else and that this is the follicle that's going to respond. But when we looked deeper, it almost looked like she had this diminished ovarian reserve picture and even possible premature ovarian insufficiency. So the reason that her uterine lining was low is, yes, she had low nutrients, but she also just had very poor response of the follicles. So a lot of it was her stress and the tension in her nervous system and how unsafe her body felt to ovulate. And there was an accumulation of issues that happened that caused her to be this way, from the childhood experiences to the teenage experiences to, there were so many issues when we actually unpacked it. It was like, oh, no wonder your body doesn't feel safe to ovulate and therefore to produce enough hormones and to essentially just let reproduction shine instead of this fight or flight system taking over. So rebuilding her nutrients and optimizing her hormones and, looking at the actual response of her follicles and what she needed helped to increase the uterine lining. And how do we know? Well, you can and go test the ultrasounds again, but really it's the menstrual cycle. If you see, I track a lot with devices like Anido, so then I could see, is the estrogen peaking more? Is the LH peaking much higher now? What's happening in the second half of the cycle? And then what is the actual volume and consistency of blood flow? And every time she was stressed, her blood flow would be a lot lower. And then when she is a lot more relaxed and things feel in control, her blood flow would be much, much better. Again, no guessing. We're just looking at exactly what each individual needs. And I'm thinking about all of these things. Do we have enough builders? Do we have to build the bricks? And then is the construction site actually safe? I know construction metaphor is probably not the best one to use for fertility, but I hope that it makes sense. Just as a recap, you guys, a thin uterine lining is a sign. It is a symptom. It is not the root cause. Your body's telling you that something upstream is going on, whether that's your nutrients, your hormones, the microbiome, any other environmental issues. Something needs attention. And then before we reach for random foods or supplements, we actually need to do proper testing. We need to look at blood work on day 2 and 3. On day 19 and 23, I would be assessing methylation. I would be assessing the vaginal microbiome. If I'm suspecting something microbial imbalance within the uterus, we can do a uterine biopsy, or we can do a deeper immune system panel to assess what's going on within the immune system. And typically we can reflect that in the immune system of the uterus. And sometimes environmental toxins are also a component. So doing a proper history and understanding everything that the body has been through will allow us to see what testing you actually need. Now, if there's any scarring or adhesions, chronic endometritis, we might need to plan for surgery, which means you need to prepare for that, optimize the body, decrease inflammation, balance blood sugars as much as we can before we go into those procedures to make sure that the body feels safe. And when we safe enough to recover, it recovers quickly. And when I look at my 3-step process that I have developed over the years, is to clarify, correct, and then conceive. Most women are jumping into the conceive phase when their body is not telling them that they're ready to conceive. And whether that's because the uterine lining is too thin or nutrients are really low, or you just feel like you're running out of time, which is a legitimate reason. The problem is, if I look at the data, if I look at the labs, if I look at your symptoms, if they're still present and they haven't been fixed, trying to conceive is just putting you into this spiral of a hopeful cycle where you're literally are grasping at straws and it doesn't feel like you're in control. Because if I look at the data, I say, well, the body isn't really ready to conceive. And that's what I think the conventional system really doesn't do for us, and that's obviously our goal here. So if you've had implantation failures, if you had, IUI or IVF cycles that didn't work because of your thin uterine lining and you're tired of guessing which food or supplement will fix it, you don't have to guess. This is exactly what we do on my team and work with our patients in the Maximize Fertility program. So if you want us to look at your history and your cycle and your labs through this holistic fertility lens, go ahead and fill out a short application down below. And if we will review and if it's a fit, we'll sit down with you and your partner and map out what it actually looks like working with us and how we can help. So thank you so much for being here. I hope you have enjoyed this podcast episode, and I'll see you next week.